the pathophysiology of an Ebola infection, and it talks a little bit about where the infection might have come from. So it starts over here with a fruit bat, um, possibly eating fruit and dropping it from a tree that might be scavenged by a gorilla, and any Ebola virus in the saliva of the bat could then transfer to the gorilla and cause an infection. Typically, individuals will scavenge bushmeat, gorilla bushmeat, and then butcher it, and then you can see how small cuts in an individual might get infected with Ebola virus. So at the site of the infection, Ebola virus will rapidly infect macrophages, which have been sent to ingest the invaders. These infected macrophages in turn produce chemoattractants like MCP1 and MIPs, these chemokines, and these recruit native macrophages to come to help in the fight, but they in turn get infected. Another type of phagocyte are dendritic cells, and they would come to the fight as well to eat up the extra Ebola particles. But again, they would get infected as well, and often when they're undergoing cell death, they round up. Cell death called apoptosis. They round up, and then eventually their membrane blebs and they die. So each of these infection processes results in a diminished localized immune response. The virus then can then make its way into the bloodstream, and that's what's pictured here, with the virus commingling with red blood cells and ends up in the lymph nodes. And then there in the lymph nodes can further deplete macrophages, dendritic cells, and again impair the host immune response. The microbes can then get into the bloodstream, and then here you see them in the bloodstream instigating clotting cascades. And then the net result is more production of cytokines, IL-8, for example, which is more about more recruitment of immune system cells, and tumor necrosis factor alpha has a lot of different functions in enhancing the immune response, and then nitric oxide, and so that also has a variety of effects. But the bottom line is these things conspire to create a vigorous immune response in the bloodstream, coupled with clotting, and then a vigorous immune response leads to damage of the vascular endothelium, and in turn leakage. And so that causes severe problems with blood pressure, severe drops in blood pressure. Later in the infection, the virus can enter the liver cells, hepatocytes, and cause dysfunction and destroy them, which actually causes a decrease in clotting factors. And so so here we have a fibrin clots early on that can cause blockage and inability to distribute oxygen. But then later on something else happens where you have a loss of clotting factors, and that can end up leading to bleeding in the gums, for example, or out of the eyes, or through. And so that's a typical. Not typical, but that's a possible downstream effect of Ebola infection, is the hemorrhaging that we're all familiar with. The virus can also enter other organs like the adrenal glands, and as a result cause necrosis of cortical cells, leading to the impaired synthesis of steroids, which are meant to control the inflammatory response. So looking more specifically at damaged endothelial cells, you can see how an infected monocyte or macrophage would produce this cytokine storm, essentially, that could then poison the endothelial cells that line the veins and arteries. And of course, the virus can actually infect them directly and destroy them. In either case, that can cause the cells to detach and release from the basal lamina, and again, vascular instability and shock as a result of all that hemorrhaging. And here we see just another version of that, the cytokine storm that's typical for Ebola, which is also something that you hear in extremely ill patients with COVID-19. So Ebola virus infects a monocyte or a macrophage and instigates a coagulation cascade, and so you get this coagulation cascade that blocks up the capillaries, as I'd mentioned before. But the rest of it you don't need to worry about. This is a interesting look at how the virus can actually suppress the innate immune response. And we see this too with SARS-CoV-2 virus as well and COVID-19. But the um, virus Ebola produces VP35, which suppresses the activation of a host enzyme called RIG1. And here you see RIG1. RIG1 works with PACT that you see here, host factor. And together, these bind to invading RNA. And in this process, will instigate downstream upregulation of interferon beta. And so interferons are necessary to be secreted from a cell and then go to adjacent uninfected cells and stimulate them to produce nucleases, for example, to as an antiviral effect. And so if a virus infects the neighboring cell, the neighboring cell will have already been alerted to the presence of the virus and will produce RNases, for example, to digest the invading RNA that the virus releases into the cytoplasm. So VP35 is really good at blocking this innate immune response. So this is just the Ebola infection in phases, and so I'm not going to read this to you, but it talks a bit about what cells are targeted, and then kind of a little bit about what I just went over in terms of spread, and then ultimately what happens in phase 2. This slide gives you a nice overview of the different symptoms, many of which you've probably heard about, but some of which maybe not. Again, a lot of it's very similar to the flu, for example, but this is a far more virulent virus, and so again, you often see the hemorrhaging, the bleeding that's typical in late stage Ebola. And so that's pictured here, so you can see the hemorrhagic rashes, which are pretty disgusting and pretty brutal, and obviously the hemorrhaging itself from the ears and the gums and so forth. And then the sort of the timeline for the pathology: day 7 to 9, headache, fever, so again, something akin to a flu, and then sudden high fever with vomiting and blood, which is obviously very different from the flu. And then we get to the more serious stuff that will eventually cause death. It can take from 2 to 21 days. It's a very long incubation period, but it's typical is about 8 to 10 days after infection for signs of Ebola to appear. Symptoms can look like the flu, and then obviously they manifest and get far worse with hemorrhaging and so forth. There's not really much you can do to fight the virus right now. There is an antibody therapy that was developed called ZMapp, and there's something similar happening with SARS-CoV-2, where individuals are being treated with the plasma of patients that have recovered. The assumption here is that the individual has some immune system components like antibodies that can be delivered to the patient currently infected, and that could swamp out the virus. But usually it's just a matter of keeping the person hydrated, through IV and giving them oxygen because of all the disseminated intravascular coagulation and so forth blocks oxygen flow, and obviously maintaining blood pressure because the individual's capillaries and arteries and veins are leaking, and that's causing severe drops in blood pressure. Survivors do develop antibodies that can be protective for 10 or more years, but again, nobody knows if you can get a new novel strain of the Ebola virus, if they're different enough that you can get a new infection, as we see with influenza, for example. It's rare, but Ebola can stay in semen, which is kind of scary too, because now it can become a sexually transmitted disease, and people didn't realize that. So after they recovered, they obviously were not protecting themselves and then spreading the virus that way. And another scary thing is the virus can stay in breast milk for 2 weeks following recovery. And so again, the nursing mothers have to worry about that as well. So contact tracing is a really big part of figuring out how to stop the infection. And so here's a patient 0, and basically it's pretty easy to kind of go through and figure out who the individuals have come in contact with sometimes, not always. Sometimes these people are walking through, big markets and so forth, and therefore it's really hard to contact trace. But the good thing about Ebola is it's not respiratory, and so the virus, or at least it's not respiratory in the same way flu is or SARS-CoV-2, where they can hover around for a while. This virus can actually requires more intimate contact, and so it's a little bit easier to trace individuals through who they had intimate contact with. This last slide just shows you the RNA virus mutation rates, and specifically I wanted you to look at the viruses that we were focusing on in this class. So HIV, Ebola 2014, influenza A, and where else? Yeah, so HIV, Ebola, influenza A, these three right here, the main ones. SARS-CoV-2 isn't on this yet, but it'd probably be down here somewhere. It's not a very mutagenic virus. But what's interesting is HIV has a very high mutation rate. Ebola 2014 actually has a higher mutation rate than influenza A, which is kind of surprising. Again, they're both RNA viruses, but influenza A has a segmented genome, which gives it that ability to reassort its RNA. So the fact that Ebola has a higher mutation rate is a little bit startling.